we begin with our next talk, that is SLE in pregnancy. This is also one of the
Yes,
frequently asked talk
yes,
article.
yes,
So it
yes,
is an autoimmune multisystem disease with relapsing and remitting course. Very specific. Female is to male ratio is 10 is to 1. Okay, more common in females,
yes,
common in the childbearing age group. Key mechanism is that immune complex deposition and the complement activation. That is what is the pathophysiology which is involved. Now, this particular
type 3 hypersensitivity.
yeah. So
Type
there is a, disease flare. There is an increased risk in pregnancy, especially if the disease is active at the time of conception. Okay. So during pregnancy, this SLE will have flare. If at the time of conception, if the disease is active, okay, and uh, the antibody like anti-DS DNA, or there is a decrease in complement level, there is a possibility of the disease flare. Okay. Then lupus nephritis. Lupus nephritis will have proteinuria, hypertension, renal impairment, and we have to differentiate it from the preeclampsia. Okay. What happens in preeclampsia? The risk of preeclampsia is increased in these patients with SLE 2 to 4 times, and late pregnancy hypertension plus proteinuria will be there. So it will be a superimposed preeclampsia in these particular patients. Hypertension, chronic or secondary to the nephritis, persistent hypertension is seen early in pregnancy. Then there can be thromboembolism also due to the antiphospholipid antibody syndrome. There can be recurrent clots formation. There can be pulmonary hypertension, very high maternal mortality, 30 to 40%, and that is a contraindication to the pregnancy. Then hematological complications like anemia, thrombocytopenia, low platelets will be there. Cardiac involvement in form of pericarditis, cardiomyopathy will be there, and patient may have chest pain, history of SLE. So these are the various complications which you see either in the pregnant or non-pregnant status, and that is why these patients are very, very high risk when we see in the obstetric. Okay. Now, how to differentiate lupus nephritis from the preeclampsia? Okay. Now, lupus nephritis can have onset anytime. There will be decrease in the complement level, and anti-double stranded DNA antibodies will be raised. Then uric acid may be normal or maybe slightly raised, because sometimes it can be associated with preeclampsia also. Then urinary sediment in form of cast and hematuria will be there, and platelets may be low. While in preeclampsia, it is seen after 20 weeks of gestation, complement level will be normal, anti-DS DNA will be normal, then uric acid will be markedly elevated, urinary sediment will be bland, and low platelets will be low in severe cases only. Okay. Now, decrease complement and increase double stranded DNA, there is a SLE flare, while increased uric acid and no immune markers, it is a preeclampsia. Okay. Now coming to the fetal complication, there can be miscarriage, stillbirth, there can be FGR, there can be preterm birth, neonatal lupus, congenital heart block, and sudden IUD. So these are the various complications which can happen. There can be a station in part 3 regarding the SLE patient who is a known case of SLE and wants to continue. So she may come for preconceptional counseling. So we need to ask this particular history. Okay, and we should explain all the complications such as miscarriage, stillbirth, FGR, preterm birth, neonatal lupus, congenital heart block, and sudden intrauterine death. And there are various SBAs on this particular thing. This miscarriage may be because of antiphospholipid antibody syndrome or the placental thrombosis, and these are the recurrent early losses. Stillbirth, mainly because of the uteroplacental insufficiency, it is a late fetal demise. FGR, because of the placental vasculopathy, and it will lead to the SGA. Okay. Then there is a possibility of the iatrogenic or the spontaneous preterm birth because of the severe maternal disease. Neonatal lupus is mainly because of the anti-Ra and anti-La antibodies. There will be rash in the neonate. Okay. Congenital heart block, again, these anti-Ra and anti-La antibodies will affect the AV node, and they will cause the damage to the AV node, and there will be persistent fetal bradycardia. Sudden IUDs are also known to happen in this patient because of the severe placental insufficiency. Okay. So these are the various complications. Okay. Now congenital heart
2%.
block,
Okay,
yeah, 2
yes,
to 3% cases, 2 to 3% cases it can happen. It is not that common, but in 2 to 3% it can happen. Generally, timing is between 18 to 24 weeks. there is a persistent fetal bradycardia, and you need to this clue will be serial fetal echocardiography uh, will be important in this particular case. Then coming to the antiphospholipid antibody syndrome, it is seen in around 30%. 1 in 3 patients of SLE will have associated antiphospholipid antibody syndrome. So these patients will be very prone for development of thrombosis. So thromboprophylaxis is very important in these patients. So antibodies are the lupus anticoagulant and anticardiolipin. Maternal risk will be arterial plus venous thrombosis. Fetal risk in form of miscarriage, FGR, and stillbirth. Placenta will show thrombosis and there will be placental insufficiency. Okay, so recurrent miscarriage plus positive lupus anticoagulant, uh, it is a antiphospholipid antibody syndrome. Okay, so risk stratification. Which are the patients which are low risk? We have already discussed. If the patient is having active disease at the time of conception, it will be a high risk case. So low risk will be if the disease is quiescent disease at the time of conception, if there is no nephritis and no antiphospholipid antibodies positive or antiphospholipid syndrome, if there is no hypertension, the outcome is almost same as general population. So counseling, when you are doing a counseling of these patients, you should tell these particular things. If the disease is quiescent, then if there is no nephritis, no antiphospholipid antibody syndrome, no hypertension, the outcome will be almost same as like a general population. But if there is an active SLE, if there is a lupus nephritis, antiphospholipid antibodies, anti-Rho and anti-La antibody positive, and there is a hypertension, there is increased maternal and fetal complication risk. Okay, so when not to conceive, if it is an active disease, if there is a pulmonary hypertension, there is a mortality of 30 to 40%, and if there is a severe organ involved. Okay, so antibody based complications like anti-DS DNA, the disease active, it is a disease activity marker. Low C3 C4, that means the disease is active. Antiphospholipid antibody will predict that there is a chances of thrombosis and miscarriage, and anti-Rho and anti-La, that is predictor for the neonatal lupus and the heart block. Okay, so coming to the antenatal monitoring, what are the things which we should monitor? The blood pressure and the urine protein. Every visit we have to see. We have to do the fetal growth scan serially. The disease activity 4 weekly, in stable cases you can call them for every 4 weeks follow-up, but the follow-up will be individualized and more frequent if the disease is more active. Okay, stable disease you can give 4 weekly follow-up. If it is an anti-Rho and anti-La antibody positive, then you have to carry out 2D echo at 18 to 20 weeks of gestation, and you will repeat 2D echo again at 28 weeks. Okay, so if it is a maternal anti-Rho or anti-La antibody positive, fetal 2D echo is indicated at around 18 to 20 weeks of gestation and repeat at 28 weeks of gestation. And now coming to the indications for early delivery. So uncontrolled hypertension, worsening renal function, severe lupus flare, early severe preeclampsia, and antiphospholipid antibody with complications. So these are the indications for the termination. Okay. So most important predictor of outcome is the disease activity at the time of conception. Most difficult differential will be lupus nephritis versus preeclampsia. Okay, because lupus nephritis is seen with the SLE, but preeclampsia will also have the similar feature. Okay, most feared fetal complication is a congenital heart block, but not very common. Okay, is seen in only 2 to 3% of cases. Most common antibody causing fetal issues is the anti-Rho. Antiphospholipid antibody, we have to think about the thrombosis and recurrent miscarriage, and complement level, that means there is a SLE flare. Okay, now differentiating pregnancy versus SLE flare. Okay, normal pregnancy related, there can be anemia, proteinuria, joint pain, thrombocytopenia, facial rash, and seizures. So this can also happen in the SLE, but the pathophysiology will be different. In anemia, there is a physiological hemodilution leading to the anemia, and there can be iron deficiency anemia also. While in SLE, it is the anemia of chronic disease, or it can be hemolytic anemia. Okay. In proteinuria,
Yes.
it may be because of preeclampsia or physiological proteinuria there can be, and in SLE it is because of the lupus nephritis. Joint pain is
Mm.
mechanical in normal pregnancy, while it is because of the inflammatory synovitis in SLE. Thrombocytopenia,
Yes.
gestational preeclampsia, and HELP. These are the causes. While here it is an immune cause. There is an immune thrombocytopenia, okay, or it can be antiphospholipid antibody syndrome. Then facial rash is a melasma or a flushing. Here there is a typical malar rash and it spreads the nasolabial folds. This is very specific for SLE. There is a malar rash, but it spreads the nasolabial folds. Then seizure is mainly because of the eclampsia, while here it is because of neuropsychiatric lupus or antiphospholipid antibody syndrome. So if multisystem
The butterfly
involvement plus
rash is
immunological markers, then think of SLE flare. If isolated hypertension, proteinuria, and after 20 weeks, think of preeclampsia. These are the uh, clues for differentiation. Okay. Now coming to the thromboembolism risk. Which are the patients which are high risk? Antiphospholipid antibody positive, then previous VTE, nephrotic syndrome,
between
and patients who are hospitalized
hospital.
because of the immobility. These are the patients are high risk for the VTE. So if it is a previous VTE, LMWH will be required throughout the pregnancy plus 6 weeks postpartum. Antiphospholipid antibody positive, then thromboprophylaxis will be required. On warfarin, switch to low molecular weight heparin in pregnancy. So postpartum, highest VTE risk is there, and you need to continue the LMWH for 6 weeks. Now, SLE flare in pregnancy. Risk is increased if there is active disease in 3 to 6 months pre-conception. So around the time of conception, if the disease is active, then SLE flare chances are increased. Most flares occur in the second half of pregnancy. So you need to monitor this particular pregnancy, blood pressure to rule out the preeclampsia, proteinuria, you need to do protein to creatinine ratio uh, for 24-hour
Yes.
urine. Disease markers will be dsDNA and complement levels. Okay. So this we have seen preeclampsia versus nephritis. Anti-dsDNA is raised, complement levels will be low, hematuria is present, RBC cast will be present. This is all present in the lupus nephritis. Okay. And there is a mild increase in the uric acid in lupus, while there is a severe increase in the uric acid in the preeclampsia, while anti-dsDNA complement level that will be normal. Okay. So that is how you need to differentiate. Then definitive diagnosis is by renal biopsy, but not indicated because pregnancy rarely done during the pregnancy, renal biopsy. Okay. So management of the lupus nephritis, you need to treat the hypertension and as per the preeclampsia protocol, you need to proceed. So target blood pressure will be 140 by 90 millimeters of mercury. Drugs are the steroids, azathioprine, and you may consider the tacrolimus also. Okay, after this specialist decision. Then fetal management. How will you monitor the fetus? Growth scan you will do every 4 weeksly. Fetal 2D echo will be done at around 18 to 20 weeks of gestation, and you will repeat it at around 28 weeks of gestation. And if this is must, if you have got an anti-Ro and anti-La antibodies positive. The uterine artery Doppler around 20 weeks of gestation, you may repeat if it is abnormal. Okay. So now what is the significance of the Doppler findings? If the PI is raised, that will indicate that it is likely to cause placental insufficiency, while if there is a diastolic notch, then there is a risk of preeclampsia. Okay. Do not treat the Doppler abnormality alone. You need to treat whole as such. Okay. Then fetal complications, there can be fetal growth restriction. It occurs in around 25 to 35% of cases, and the risk is increased with the lupus, APS positive cases, and hypertension. Congenital heart block is seen in around 2 to 3% of cases. The cause is anti-Ro and anti-La antibodies. Timing is between 18 to 28 weeks of gestation. Generally, the heart rate is continuously between 60 to 80 beats per minute. There is a fixed bradycardia. The recurrence risk is 16%, doctor. So not only prevalence you remember, but remember that the recurrence risk is 60%. Outcome 50% will require a pacemaker. Then coming to the neonatal rash, neonatal lupus rash. Okay, this is seen in annular lesions in the area of face and scalp. Timing generally after 2 weeks and can happen up to 3 to 6 months also. Generally, it is because of maternal antibodies which cross the placenta, and generally it gets resolved by around 6 months. Okay, preterm delivery may be because of the preeclampsia, fetal distress, FGR. PROM risk is around 20% and increase with the steroid use. Then what is the treatment? The safe treatment is a prednisolone. Steroids are safe. Azathioprine, and hydroxychloroquine. So these are the treatment modalities for SLE. But when you start prednisolone, what are the things which you need to monitor? Mainly screening for the diabetes mellitus. Okay, so prednisolone is the first line, and it has got a low fetal risk. Azathioprine is safe, and you can continue during the pregnancy if she is already on azathioprine. Hydroxychloroquine will prevent the flare. You don't have to stop this hydroxychloroquine during the pregnancy. Okay, with NSAIDs, we have to be very cautious because these patients can have a renal parameter deterioration. It is to be avoided after 32 weeks of gestation because there is a ductus arteriosus closure. Okay,
Okay.
which drugs are contained in methotrexate that can lead to the neural tube defects, mycophenolate mofetil that is also known to cause miscarriage and malformation, and cyclophosphamide is also teratogenic. Okay, so hydroxychloroquine will reduce the flare and you must continue it. Steroids, there is a risk of GDM, so screen these patients for GDM, and NSAIDs are to be avoided in the late pregnancy. So drug-induced lupus, it is seen with the hydralazine, procainamide, isoniazid, minocycline, and diltiazem. Now these patients, there is no, this does not cause flare in the established SLE. These patients, these drugs can cause SLE, but in established case SLE, there will be no flare because of the use of these particular drugs. Then postpartum, what we need to do? There is increased risk of SLE flare in the postpartum period. So we need to continue the thromboprophylaxis for 6 weeks, avoid estrogen containing contraception, manage hypertension and the renal disease. Okay. Now let us see the highlights. Okay. So most difficult diagnosis is SLE nephritis versus preeclampsia. Most important antibody is the anti-Rho antibody that will lead to the heart block. Most important drugs is a hydroxychloroquine. Then most dangerous is a maternal condition is a pulmonary hypertension. Most common cause of preterm is a preeclampsia. And best predictor of outcome is the disease activity at conception.